Welcome to the deep dive. Today we're tackling a really important topic, breast cancer. We've got the revision notes right here in front of us.
Yep, pretty detailed set of source material.
And our plan is to, unpack it all for you, really get down to the essential stuff, the high yield knowledge you need, especially if you're revising.
Exactly. Our goal is to help you get to grips with the core concepts, the details that really matter, so it all clicks, and crucially, you can recall it when needed.
Right, and we're covering the whole spectrum based on these notes, definition, causes, risks, right through to how it's managed and the outlook.
Pretty much everything from start to finish.
Okay, then, let's dive in. Remember, we're guided solely by the source material provided. So, kicking us off, the definition. What exactly is breast cancer, fundamentally, according to these notes?
Right, well, at its heart, the source defines it as the uncontrolled growth of abnormal cells. And these cells originate within the breast tissue itself. What's really key here, and the source highlights this, is where they usually start. Two main places. The ducts, think of them as the little pipes carrying milk. That leads to ductal carcinoma.
Ah, okay, ducts.
Or the lobules. They're the glands that actually produce the milk, and that's lobular carcinoma.
Got it. Ducts and lobules. And the source emphasizes it's heterogeneous. That sounds significant.
It really is. It just means breast cancer isn't one single disease. It's actually a diverse group of conditions. They could look different, grow differently.
Right, so not all the same.
Not at all. And a key distinction the source makes is between non-invasive or in situ, meaning it's contained, hasn't spread out of that duct or lobule.
Like DCIS.
Exactly. Ductal carcinoma in situ is a prime example. Or it can be invasive, meaning the cells have broken through that initial boundary and have the potential to spread.
And the notes also flag a couple of maybe less common specific types, Paget's disease and inflammatory carcinoma.
Yes, they get a specific mention. Paget's disease is interesting. It involves the nipple skin, starting in the ducts but affecting the epithelium there. Inflammatory breast cancer is quite distinct too.
So.
Well, the source describes it as often not presenting with a distinct lump. Instead, it causes rapid swelling, redness, warmth. The breast might look inflamed, almost like an infection, but it's actually a malignancy. Needs quick recognition.
Oh, okay. So thinking about those two main starting points, ducts and lobules, for remembering, maybe. Ducts are for drainage, carrying the milk away, and lobules are for lactation, making it.
That's a great way to connect them. Ducts for drainage, lobules for lactation. Simple and effective.
And ductal is the more common one, you said.
That's right. The source indicates ductal carcinoma is significantly more common.
All right, so once we understand what it is, the obvious next question is why? Why does it happen? The source material is pretty clear that we don't know the exact single cause.
No, there isn't one definitive cause identified. But, and this is crucial, we understand a lot about the factors that increase the risk. The sources really point to a few key areas. Genetic factors are a big one, especially specific mutations like in the BRCA1 and BRCA2 genes.
Why are they so important?
Because those genes normally help repair damaged DNA. If they're mutated, that repair process doesn't work properly and errors can build up, leading to cancer.
Makes sense.
Then there are hormonal influences, things related to a person's lifetime exposure to hormones like estrogen and progesterone.
Right.
And finally, the sources mention environmental factors and lifestyle choices also playing a part. It's complex.
So just to be clear, having something like a BRCA mutation doesn't automatically mean someone will get breast cancer?
Absolutely not guaranteed.
Yeah.
But the source is clear. It significantly increases the risk. It's about probabilities.
Okay.
It's this combination: genetics, hormones, lifestyle, maybe other factors interacting over time.
Right. That leads us nicely into the risk factors section in the notes, which looks quite detailed. What are some of the really big ones that stand out?
Yeah, there's a fair bit listed here. What jumps out first is just age. It's a major factor. The risk goes up significantly after 50. That's why screening targets that age group.
Okay, age. What else?
Family history is definitely key. Having a first-degree relative, a mother, sister, daughter with breast cancer, increases risk. The source even puts numbers on it, like 6 to 19% of women with breast cancer have that kind of family history.
Wow, okay.
And those genetic mutations, BRCA1 and 2, are mentioned again here, with some pretty stark lifetime risk percentages listed in the source, up to 85% for breast cancer with BRCA1. And importantly, the notes remind us these affect men too, increasing their risk, although male breast cancer is much rarer overall.
And hormones seem to be a recurring theme across these notes. Things like starting periods early, going through menopause late.
Yes, and also having a first baby after 30 or never giving birth at all, nulliparity it's called. Not breastfeeding is also listed.
Why do those things increase risk? Is it just length of exposure?
Essentially, yes. According to the source material, these factors all relate to the cumulative number of menstrual cycles and the overall time the breast tissue is exposed to higher levels of endogenous estrogen and progesterone without the interruptions of pregnancy and lactation. More cycles, potentially more chances for cell changes.
I see. And what about external hormones like HRT or the pill? The sources mention those too.
They do, and with some important nuances. Combined HRT, that's estrogen and progestogen, is linked to an increased risk, and that risk seems related to how long you use it. But estrogen-only HRT, the source suggests, shows minimal change in risk.
Interesting distinction.
Yeah. And for the combined oral contraceptive pill, COCPs, the source mentions a slight increase in risk while using it and shortly after, but this extra risk seems to diminish over about 10 years after stopping.
Okay. What else? Radiation.
Yes, radiation exposure, especially significant doses to the chest area, particularly at a younger age, is listed as a clear risk factor.
And lifestyle. Things like weight, diet, exercise.
The sources include those. Obesity, particularly after menopause, a sedentary lifestyle, and what's termed a Western-style diet, are all noted as contributing factors. Alcohol consumption gets a mention too as increasing risk.
Right. Lots to take in there. Oh, and the source actually makes a point about breast implants.
Yes, it specifically notes that having breast augmentation implants does not seem to increase the risk of developing breast cancer itself.
Yeah.
Good point to clarify.
Okay, that's a very long list of risk factors. Trying to remember them all. Maybe we can group them. You mentioned hormones, genetics, lifestyle. What else? History?
That's a
Radiation?
good way to think about it. Maybe something like hormonal factors, genetic predispositions, lifestyle choices, history, personal or family, and radiation, HGLHR.
HGLHR. Yeah, grouping them like that definitely helps chunk the information, makes it feel a bit more manageable for revision.
Absolutely. Those categories cover the main areas the source material focuses on.
Okay, so we know the risk factors. Now let's zoom in a bit on the how. How do these abnormal cells actually grow and spread? The pathophysiology bit in the notes.
So it starts with those triggers we talked about, genetic mutations, DNA damage. These mess up the normal rules controlling how cells divide and die.
Right. The normal checks and balances fail.
Exactly. So you get abnormal cells multiplying when they shouldn't, and they don't die off when they should. This forms a clump, a primary tumor, usually starting in a duct or lobule.
And then it becomes invasive.
That's the critical step. The cells develop the ability to break through the basement membrane, the wall of the duct or lobule, and invade the surrounding breast tissue. That's invasive cancer.
And from there?
From there, they can get into the lymphatic channels or the small blood vessels within the breast. That gives them a route to travel first, maybe to the lymph nodes in the armpit, the axilla, and potentially then to distant parts of the body. That spread is metastasis.
And different types might spread differently.
Yes, the source indicates that different subtypes, based on things like their receptor status, can have different patterns of growth and tendencies to metastasize.
Okay. Now, thinking clinically, if someone finds a lump or notices a change, it's obviously a worry, but the notes say it's often not cancer. What are some of the other things it could be? The differential diagnoses.
Yeah, this is so important. Most breast lumps or changes are benign, not cancerous. The source lists quite a few possibilities. Things like fibroadenomas, they're common, benign, solid lumps.
Right.
Or just general fibrocystic changes, which can make the breasts feel lumpy, maybe tender, often related to the menstrual cycle. Simple cysts, fluid-filled sacs are also very common.
What about infections?
Definitely. An abscess, which is a collection of pus, can form a lump. Mastitis and inflammation or infection of the breast tissue often causes redness, swelling, pain, maybe a lump. And sometimes an injury to the breast can cause fat necrosis, where damaged fatty tissue forms a lump that might feel hard.
So lots of possibilities. Investigation is key.
Absolutely. You need the triple assessment, which we'll come on to figure out what's going on.
Okay. Before we get to investigations, let's look at the bigger picture again, the epidemiology. How common is breast cancer? Who does it affect most? The UK stats in the source material sound pretty stark.
They really are. The source clearly states it's the most common cancer overall in the UK. Accounts for about 15% of all new cancer cases.
15%? Wow.
And it overwhelmingly affects females. About 99% of cases are in women. The source quotes around 50,000 new cases diagnosed in UK women each year. And as we said with risk factors, the incidence rate climbs quite steeply with age.
Any trends mentioned?
Yes, the source notes that female incidence rates have actually been increasing over recent decades, while the rates for male breast cancer have remained relatively stable, though it's always been much rarer in men.
Okay. And the notes also mention something about where in the breast it occurs most often and a link to deprivation.
That's right. The upper outer quadrant of the breast, sort of the area towards the armpit, is cited as the most common location for invasive cancers. And interestingly, the source notes that for females, incidence rates are actually lower in the most socioeconomically deprived areas compared to the least deprived.
That is interesting. Any reason given?
The source just presents the statistic, doesn't delve into the reasons why that might be. It does note, though, that for male breast cancer, the rates are similar across different levels of deprivation.
Okay. So, moving to clinical presentation, what are the typical signs and symptoms someone should look out for, according to the notes?
The most common thing, by far, is finding a breast lump or an area of thickening. The source points out this is often painless, which can be misleading, but sometimes it is associated with pain or discomfort.
So painless doesn't mean harmless.
Definitely not. Other key signs to be aware of, listed in the notes, include changes in the size or shape of the breast, any changes to the nipple, like it suddenly becoming inverted or pulled in, or having a discharge, especially if it's blood-stained. That can be linked to intraductal carcinoma.
Okay. Nipple changes, what else?
Skin changes on the breast are important too. Things like dimpling or puckering of the skin, redness or swelling, skin looking like orange peel, peau d'orange, or even ulceration in advanced cases. Oh, and finding a lump or swelling in the armpit, which could be an enlarged lymph node.
And the notes specifically say pain on its own isn't usually cancer.
Yes. The source states that breast pain alone, without any other changes or lumps, is rarely a sign of breast cancer, though obviously persistent pain should still be checked out.
And understandably, the notes mention patients are often very anxious when they present with symptoms.
Of course. It's a very worrying thing to find a change. And the source also touches on symptoms that might suggest the cancer has spread, become metastatic.
Like what?
Things like persistent bone pain, perhaps in the back or hips, jaundice, yellowing of the skin or eyes, could suggest spread to the liver. Breathlessness or a persistent cough might mean lung involvement. And lymphedema, swelling in the arm, can occur if lymph nodes are heavily involved. General symptoms like unexplained weight loss, drenching night sweats, or loss of appetite can also sometimes signal advanced disease.
This really highlights the importance of screening, doesn't it? Which the source mentions for the 50-70 age group in the UK.
Absolutely. The NHS breast screening program is designed to pick up cancers early, often before they cause any symptoms at all. And the sources really stress that finding cancer early dramatically improves the chances of successful treatment and long-term survival. Mammography is the tool used.
And why not screen younger women?
The source explains that mammography is generally less effective in women under 40 or so, because younger women tend to have denser breast tissue, which can make it harder to spot abnormalities on the X-ray images.
Got it. So if someone does have a symptom, or screening picks something up, what happens next? The investigation pathway detailed in the notes.
This is where the triple assessment comes in, which the source describes as the standard approach. It has 3 parts.
Okay, well, what are they?
First, a thorough clinical examination of the breasts and armpits by a healthcare professional. Second, imaging. Usually a mammogram if the person is over 40, or an ultrasound, particularly for younger women under 35, or to get a better look at a specific lump found on examination or mammogram. Sometimes an MRI is used in specific situations.
And the third part?
Biopsy. This is crucial, taking a sample of the tissue from the suspicious area to look at under a microscope.
And that confirms if it's cancer, but also gives more detail.
Exactly. The biopsy confirms malignancy, but the source emphasizes it also provides vital information about the cancer's characteristics. Things like the grade, how abnormal the cells look, which relates to how aggressive it might be. The K67 index, which measures how fast the cells are dividing. And, absolutely critically, the receptor status, testing the cancer cells for estrogen receptors, ER, progesterone receptors, PR, and HER2 protein status. This is fundamental for guiding treatment choices.
What kind of biopsy is usually done?
The source mentions fine needle aspiration, FNA, might be used, especially for lymph nodes perhaps, but often a core biopsy is preferred for the breast lump itself. It takes a slightly larger sample, which gives more tissue for that detailed analysis, including the architecture.
And there are specific referral guidelines mentioned too, for GPs.
Yes, the source outlines the NICE's guidelines for suspected cancer pathways. Essentially, an unexplained breast lump in someone 30 or over needs an urgent 2-week wait referral. Same for certain nipple changes in those 50 or over. Younger patients, under 30, with a lump might be referred non-urgently initially, depending on the clinical picture.
And genetic testing for high-risk people.
Yes, the source highlights the importance of considering genetic counseling and testing for BRCA mutations, particularly for individuals diagnosed young, say under 50, especially with triple-negative breast cancer, or those with a strong family history suggesting an inherited risk.
Okay. And once cancer is confirmed, there's staging.
Yeah.
To see how far it's spread.
Correct. Staging investigations are key. The source mentions this usually involves checking the lymph nodes in the armpit, often with an ultrasound and maybe a biopsy if they look abnormal. And for potentially more advanced disease, scans like CT of the chest, abdomen, pelvis, maybe bone scan or PET-CT are used to look for any signs of spread to distant organs.
And this all feeds into the TNM score.
Exactly. The source details the TNM system, tumor size, node involvement, metastasis. It's a standard way to classify the extent of the cancer, which is vital for planning treatment and estimating prognosis.
Okay, so that triple assessment, again, for memory, examination, imaging, biopsy, EIB.
EIB. Yeah, that works.
And the key receptors tested are ER, PR, and HER2. Those seem crucial.
Absolutely crucial for determining treatment pathways. You really need to know those.
Right. So diagnosis confirmed, staging done. What about treatment? What options are outlined in the source material?
Management is usually a combination of approaches, and the source stresses it's tailored to the individual, the type and stage of cancer, receptor status, patient's health and preferences. But the main pillars are surgery, radiotherapy, and systemic therapies.
Let's start with surgery.
Okay, surgery is often central. The main options described are lumpectomy, also called wide local excision or breast-conserving surgery, where just the tumor and a surrounding margin of healthy tissue are removed, or mastectomy, where the entire breast is removed. The choice depends on factors like tumor size, location, whether there are multiple tumors, and patient choice. Lymph node surgery, like sentinel node biopsy or axillary clearance, is often done at the same time.
And radiotherapy.
Radiation therapy is very commonly used, especially after lumpectomy. The source explains its purpose is to destroy any microscopic cancer cells left behind in the breast tissue, reducing the risk of the cancer coming back in that area, local recurrence. It might also be used after mastectomy in some cases, or to treat areas where the cancer has spread.
Okay. And systemic treatments, those that travel through the whole body.
Yes, these are vital for tackling any cancer cells that might have escaped the breast. Chemotherapy is a major one, using drugs to kill cancer cells. The source mentions it can be given before surgery, that's neoadjuvant chemo, often to shrink a large tumor to make surgery easier or possible, or after surgery, adjuvant chemo, to reduce the risk of recurrence.
And hormone therapy.
That's crucial for hormone receptor-positive cancer, so ER or PR positive. The source explains these therapies work by blocking the effects of estrogen on the cancer cells, or reducing the amount of estrogen in the body. Drugs like tamoxifen or aromatase inhibitors are key examples mentioned, usually taken for 5–10 years.
And targeted therapies.
Yes, these are designed to target specific molecules involved in cancer growth. The most well-known example from the source is for HER2 positive breast cancer. Drugs like trastuzumab, Herceptin, specifically target the HER2 protein, significantly improving outcomes for this subtype.
The notes also mention some newer or more advanced options and tools to help decide treatment.
They do. It shows how personalized treatment is becoming. The source mentions prognostic tools like Predict, which helps estimate survival benefits from different treatments, and genomic tests like Oncotype DX or EndoPredict, used for certain ER-positive HER2-negative cancers to analyze tumor genes and help decide if adding chemotherapy to hormone therapy is actually beneficial based on the recurrence risk score.
That's quite sophisticated.
It is. The source also lists specific drugs approved for certain situations like pembrolizumab, an immunotherapy for some triple-negative breast cancers, or olaparib, a PRP inhibitor, for patients with BRCA mutations and high-risk disease. And bisphosphonates are mentioned for managing bone health, both as an adjuvant treatment in some postmenopausal women and for treating bone metastases.
Okay, that's a lot of treatment modalities. To recap the main types: surgery, radiation, systemic therapies, which includes chemo, hormone, and targeted, SRS.
SRS, yep, covers the big 3 categories nicely.
So with all these treatments, what's the general outlook? What does the source material say about prognosis?
Prognosis is really variable. And the source lists the key things it depends on. The single most important factor is the stage of diagnosis, basically, how advanced the cancer is. Tumor size, whether it's spread to the lymph nodes, and especially whether it's spread to distant organs, metastasis, are critical.
And the tumor biology matters too.
Absolutely. The greater the tumor, its receptor status, ER, PR, HER2, how fast it's growing, like the Chi-67 index, these all provide prognostic information. And of course, the patient's overall health and age play a role.
But the take-home message seems to be that finding it early is key.
Definitely. The source strongly emphasizes that early detection, through screening or prompt investigation of symptoms, leads to treatment starting at an earlier stage, which significantly improves the chances of cure and long-term survival.
And the progress sounds quite remarkable.
It really is. The source highlights the dramatic improvements in survival rates thanks to better screening, diagnosis, and particularly the advancements in treatment over the last few decades.
Do the notes give actual survival stats for the UK?
Yes, they do provide some headline figures. For England, it states that almost 76%, so more than three-quarters of women diagnosed with breast cancer, now survive for 10 years or more.
That's amazing.
And it includes the statistic that the 10-year survival rate has effectively doubled over the last 50 years in the UK, which is incredible progress. Survival is noted as being highest in the 55-64 age group.
What about male breast cancer prognosis?
Unfortunately, the source notes that prognosis for male breast cancer tends to be poorer than for female breast cancer, with lower survival rates. The reasons are likely complex, possibly including later diagnosis, and it mentions using prognostic scoring systems, combining various factors to give a more individualized estimate of recurrence risk.
Okay. Finally, the source covers complications. These can come from the cancer itself or the treatments.
Yes, both. It's an important part of the overall picture. Complications from the cancer itself include local recurrence, the cancer coming back in the same breast or chest wall area after treatment.
And the most serious complication?
Metastasis. Cancer spreading to distant organs. The source lists common sites like bone, liver, lungs, and brain. Metastatic breast cancer is generally not curable, although treatment can often control it for periods, sometimes many years, but it's the main reason people die from breast cancer.
And complications from the treatments sound like they can be significant too.
They certainly can be, and the source details quite a few. Chemotherapy side effects are well known, things like fatigue, hair loss, nausea, increased risk of infection because it affects bone marrow. Radiotherapy can cause skin reactions and fatigue.
What about hormone therapy side effects?
Those can be challenging too. Things like hot flushes, vaginal dryness, joint pain, mood changes, basically inducing menopausal symptoms or making them worse. And a really significant potential long-term complication mentioned is lymphedema.
The arm swelling.
Exactly. Swelling, usually in the arm on the same side as the surgery, caused by disruption to the lymphatic drainage system from lymph node removal or radiotherapy. The source lists management, like specialist physiotherapy, skin care, compression garments, and manual lymphatic drainage massage.
And the emotional impact is highlighted too.
Yes, very importantly. The source points out the huge emotional and psychological toll of breast cancer diagnosis and treatment. Can take anxiety, depression, body image issues are common. It stresses the need for psychological support as part of comprehensive care.
Are specific management strategies for complications mentioned?
Yes, briefly.
Yeah.
Things like managing fatigue, using bisphosphonates or radiotherapy for bone pain from metastases, specific treatments like surgery or radiotherapy for brain metastases, physiotherapy for mobility issues, and importantly, how to manage treatment-induced menopausal symptoms, recommending non-hormonal options like certain antidepressants, SSRIs, or clonidine, as HRT is usually contraindicated.
Wow. Okay, that was a really comprehensive run-through of the source material on breast cancer. We've covered a huge amount of ground, from the very basics of the cells involved right through epidemiology, diagnosis, the complexities of treatment, and the long-term picture.
It definitely highlights what a complex field it is.
Yeah.
But also, the real progress that's been made, especially in treatment and survival, is quite striking when you see stats like survival doubling.
It really is. But the notes also showed incidence rates are still high, even increasing in some groups, and it remains the most common cancer. So that leaves us with a final thought for you, the listener, to mull over. Based on everything we've just discussed from these notes, the risk factors, the biology, the screening, the treatments, the challenge of metastasis, what do you think is the single biggest remaining challenge or the most crucial next step in the fight against breast cancer today? Is it pushing for even earlier detection? finding better ways to tackle those lifestyle and environmental risks across the population? Or is the ultimate prize cracking the code of metastasis? Or even preventing those first abnormal cells from ever developing? Something to think about.
Definitely food for thought.
Yeah.
And remember, really understanding how all these different aspects connect the pathophysiology, the risk factors, the trait and rationale, that's what will help consolidate this knowledge for your revision.
Absolutely. And if you are prepping for the MSRA or just want more structured learning resources, you can find more materials related to breast cancer and many other topics over at passthemsra.com.
And don't forget, for free revision questions and notes, check out freemsra.com.
Thanks so much for joining us for this deep dive. We'll catch you next time.